Welcome to today's webinar in World Haemophilia Week on World Liver Day. We're very excited about this particular talk because we have three very great speakers today, and we're very lucky to have them joining us. We have the Associate Professor of Internal Medicine from the University of Milan, Vincenzo Mura. We have Clive Smith from the UK Haemophilia Society, and we have Brian O'Mahony from the Irish Haemophilia Society. So before we get started and I hand over directly to Vincenzo, I just want to really highlight a couple of key things as we're listening to it, because I think historically in the bleeding disorder world, when we hear about liver, we think specifically about hepatitis C and the history and all of those aspects. But I want to really say that, who is this webinar for? And it is primarily for people who have had hepatitis C within our community, who have significant liver damages as after probably clearing hepatitis C, people who had hepatitis C who have no or very little liver damage after they clearing hepatitis C, but also, and I think more importantly, a general population, not just previously exposed, but a general population who have never been exposed, and because of lifestyle and diet have some considerations to be planning for a healthy aging and healthy liver. And I think that is very important for two key reasons in terms of if you're going to make an impact in terms of your liver health over the long term, you have to start as early as possible. And that's why we're our main focus of today. But we also have a number of new therapies coming down the line in terms of gene therapies, and they may be available in the future for everybody with a bleeding disorder. And the question is, how do I make sure that everything is in the best form as possible if that becomes a consideration in the future? So with that insight, I hand over to Vincenzo to take us off in terms of the introduction around liver health. Vincenzo.
Hi, good afternoon, Declan. Thank you very much for this invitation in the World Liver Day. My topic, as you introduced, is talking about liver health in the world of hemophilia that has several important consequences for the health of our people. These are my disclosure today. And we have to start our speech giving an overview of the natural history of any chronic liver disease and the clinical risks associated with the evolution of a chronic liver disease. Indeed, whatever the etiology, any chronic liver disease can evolve toward a compensated cirrhosis, and this can go toward a decompensated cirrhosis. They are all different stages of risks associated with the possibility of portal hypertension related events, among them the development of ascites and upper gastrointestinal bleedings are the well-known liver related consequences, but also hepatocellular carcinoma, death, and need of liver transplantation. In this scenario, the higher the severity of the disease, we know that we have a higher risk of clinical complication. And our task as hepatologists, of course, consists in diagnosis, preventing, and treating any problem related with this liver disease. But how this scenario apply in the hemophilia world? Up to the first years of 2000, we are clear that the problem was the high prevalence of HBV, ACV, and HIV infection. We know that HIV co-infection can accelerate liver fibrosis, and also 20–30% of people with hemophilia could develop an end-stage liver disease, with complications, among them hepatocellular carcinoma, the most important. For all these complications, we could also offer a liver transplantation, but there are several problems related with people with hemophilia, because there are problems, of course, related with this very invasive surgery. But in expert sense, it was possible, and it is a very well technique developed in our hemophilia, in the most important European hemophilia centers. And liver disease, we know in the hemophilia world, are the most common causes of death. It was a big problem up to the advent of several solutions related with the advent of recombinant factors, which reduced the exposure of people with hemophilia to blood-derived products. Also, an important impact was given by the vaccination policy against HBV and HIV, and the advent of efficacious antivirals against HPV, HCV, and HIV was a real successful etiological approach. So, what about today? Is still a room for hepatologists in the hemophilia world after this happy ending story, at least related with the etiology? The present start with this important paper from eminent scientists very active in the world of hemophilia, giving this call to launching this call to action for a strong collaboration between hematologists and hepatologists. And this was so important that was the first keywords at the beginning of this document appeared in the Journal of Hepatology, which is the official journal of the European Association for the Study of the Liver. And of course, this manuscript was pushed by the advent of gene therapy. But I think that for an exhaustive guide for patients, we have to understand several key points today related with why liver health is still an issue for the hemophilia world, how to maintain liver health in this clinical setting, and when the referral to a hepatologist is mandatory. Let's go to the first point, why liver health is still an issue. Liver is certainly a target of adeno-associated virus-based gene therapy, and there are several concerns for that related with the possibility of an hepatotoxicity associated with this innovative therapy. Indeed, the randomized controlled trials have demonstrated acute liver damage, as showed by the elevation of aminotransferase, the so-called transaminidase. But also there are some frightens related with the chronic liver damage due to the development of fibrosis, hepatocellular carcinoma, and potential other vascular or less specific chronic liver diseases. I will go very fast on that, telling you that authorities, companies, physicians, patients associations, consortia are working very hard to optimize the benefit-risk ratio of adenovirus-based gene therapy. And this is enough to understand that around the world of gene therapy, there are lots of effort to improve the quality of life of our patients. But I think we have to move a step backward. We have to go to the etiology of the liver. This is, I think, the most important point beyond gene therapy. And the etiology can be distinguished in virus-associated or not virus-related. And for each chapter, we have some important question to answer. For example, for virus, the question could be, does etiological therapy warrant lifelong liver health? And for non-virus related etiologies, what's the real impact on liver health? Let's go to the first point, virus etiology. We have very important real-life data in patients with cirrhosis at the time of HCV clearance. This is an important paper from Milan, Roberta D'Ambrosio, demonstrating us that people, after achieving the clearance of the virus, have a residual risk of developing liver-related complications, among them hepatocellular carcinoma, portal hypertension-related events, liver death, that could achieve very high proportion depending on the stage at the basal value. In other words, the higher the severity of the disease before HCV clearance, the higher the residual risk of complication. And as you can see here, the risk can achieve up 70% in patients who were at a very advanced stage of liver disease, as represented here by patients with child B cirrhosis, or patients with previous history of hepatocellular carcinoma. But beyond the viral etiology, we know that the epidemiology is showing us that alcohol can represent a large proportion of death related with liver disease. This is particularly true for the East Europe, but there is an important warning related with non-alcoholic fatty liver disease and NASH, that are the typical liver hepatitis associated with the metabolic disorders, among them obesity. And this is extremely important also in the hemophilia populations. Indeed, we know that people with hemophilia can suffer from obesity with a prevalence around 25%. And also, if we give a look to the most important data on the incidence of hepatocellular carcinoma, non-alcoholic steatohepatitis, previous HCV infection, and also the comorbidity, the burden of comorbidity as represented by the Charson Comorbidity Index, are significant risk factors for hepatocellular carcinoma in hemophilia, even after HCV clearance. So liver health is certainly still an issue, but how to maintain liver health among people with hemophilia? We can give several advices for that. Some do, some don't, can be recommended. For example, maintaining a healthy body weight, making physical exercise regularly, eating safe food and drink, getting vaccinated against hepatitis B and hepatitis A, having a tight medical control if exposed to any risk factors, and some don'ts. Among them, excess of alcohol, unsafe injection, unnecessary drugs, also take care of herbal products and dietary supplements that can expose patients to an unnecessary risk of acute hepatitis, tattooing in unregulated setting, unsafe surveillance. In other words, liver health at this step is really in our hands. But the problem is when we have to refer a patient to an hepatologist. This does not occur based on our biochemistry. I want to start and point out this important data, that sometimes even patients suffering from liver cirrhosis or chronic hepatitis can have a normal level of aminotransferase. So the biochemistry cannot guide our final decision for a referral to a hepatologist. And what should guide our final decision? Of course, candidates to gene therapy need to be tightly observed and visited by hepatologists, just in order to balance the benefits and the risk associated with the gene therapy. But we have also other important factors to take into account. First of all, people with exposure to risk factors, just to treat these risk factors or control them by the introduction of etiological therapies. And also in those patients who already suffer from an advanced chronic liver disease, we have to put our efforts to pursue a primary prevention of complication. And another setting is that related with patients already suffering a liver-related complication, just to treat them and to prevent a new appearance of further complications or considering them for liver transplantation. It's important to understand that this general rule can be applied despite the candidacy to gene therapy. And I want to share with you some of our data at the Angelo Bianchi Bonomi Center, directed by Flora Beivandi. This is our experience in Milan of a tight screening, a pathological screening in 160 patients from November 2020 and January 2023, made by two hepatologists who are staff member of the group of the hemophilia, of these hemophilia centers. These data have been already presented at the last meetings, the ASH meeting and the HIAD meeting, and full data will be presented at the next ISTH in Montreal. But as you can see in this table, we can differentiate people with hemophilia, ACV exposed, and
И
ACV
мы
never
видим,
exposed. We can
что
compare them with the
можно сравнить пациентов, у которых был гепатит С и у которого не было гепатита С, и посмотреть на другие наследственные геморрагические заболевания. И мы видим до 80% вне зависимости от клинической картины имеют потенциальные факторы хронического повреждения печени. Это наиболее распространенные факторы. Ну, естественно, избыточный вес и алкоголь. И до 16% пациентов даже после излечения вируса имеют определенные признаки, которые указывают на очень выраженное проявление такого заболевания печени, как цирроз. И да, некоторые получают диагноз гепатоцеллюлярная карцинома, и некоторым делают пересадку печени. Вот в нашем центре таких было 3, а один сейчас проходит оценку на пересадку печени. Именно поэтому очень важно понимать, что нам нужна мультидисциплинарная команда для лечения таких пациентов, куда входит гепатолог, играет очень важную роль. Он информацию передает и конкретную, и статистическую гематологу. И наличие выделенного специализированного хирурга, который занимается пересадкой именно печени в гемофилических медицинских учреждениях, тоже будет важным. И должен еще работать радиолог не только для визуализации, но и для проведения инвазивных радиологических методов лечения, которые сопровождают трансплантацию печени. Выводы. Болезнь может по-прежнему прогрессировать, особенно у пациентов, у которых был цирроз до излечения от гепатита С. Потенциальные риски фактора хронического повреждения печени часто наблюдаются у пациентов с гемофилией, и достаточно значительная доля пациентов с гемофилией требует специализированную, так сказать, третичную медицинскую помощь для поддержания здоровья печени. И в этом случае нам вот необходимо именно работать мультидисциплинарно, и где бы гепатологи и гематологи работали вместе и улучшать жизнь наших пациентов с гемофилией, особенно в эру генной терапии. Вот на этом я заканчиваю. Всем желаю счастливого дня гемофилии и дня здоровой печени.
So next up we have Clive Smith, who will take liver health from a patient perspective and have a conversation about what, from an individual patient perspective, we really need to be thinking about moving forward with liver health.
Good afternoon, everybody. My name's Clive Smith. I am a patient with severe haemophilia A, and I'm going to discuss liver health from a patient perspective with you this afternoon. For those of you who were in Copenhagen back in October, you'll remember Declan and others when this matter was discussed there, saying that what we wanted to do at the HC is to start a new conversation in relation to liver health. It's something that's very much gone on to the back burners, or indeed not been spoken about at all in some quarters over recent years. And so it's important that we start this new conversation. And we did that at the end of last year. And it's really good to see this being highlighted again today, and that conversation being continued as we promised to back in October. So this is a continuation of that. So please don't think that today is the end of it. There'll be much more to talk about and discuss as we go on in the future. So why is it important then to people with haemophilia and bleeding disorders? At the moment, we've been talking a lot about aging, and I'll come to that a bit later as well, to redefine a little bit as well what we mean when we talk about aging with bleeding disorders too. But we're very much redefining what comprehensive care teams looks like. We're moving away from perhaps the classic model of the hematologist, the nurse, the physiotherapist, and the psychologist. And we're now talking about other disciplines being involved in that, in terms of geriatricians, for example, hepatologists, virologists, all those sorts of people, some people who have been involved in the past, some people who haven't. And so while we're redefining it, it's a good time to then bring liver health back into that conversation. In terms of the aging population, for many who are aging now with bleeding disorders and haemophilia, this presents a new challenge for our community, because in the past, we haven't really had people who've been aging. And when they have been aging, they've been aging perhaps with different challenges to ones that we're facing today. So although this is something we have had to deal with in the past, it's a growing issue and something that undoubtedly more light and more focus needs to be shed on. Vincenzo's mentioned already and referenced gene therapy, and I know that's very much the focus of what we're talking about in terms of why we're looking at current and prospective treatments. And that, of course, has made liver health important once again. But as well as this known that we know about, there are potentially, of course, known unknowns. There may be future treatments that may impact on the liver as well that we don't yet know about. It may be that kidney health becomes important in the future. It may be that cardiovascular health becomes important with new treatments. We simply don't know. What we do know is at the moment, liver health is very much at the forefront of our minds. And so we have to start talking about liver health and physical health generally. I know Vincenzo mentioned physical exercise, and I've categorized it there as physical health, and I'll come back to that in a few moments for reasons I'll explain. So what are the challenges? Vincenzo set out very clearly the challenges from a medical perspective, but on a more simplistic level for those of us dealing with these things day to day. We know, of course, that liver health and gene therapy and the way they interact is not yet fully understood. It's very much an evolving landscape. And I think it's very important that we're honest with each other, that we don't have all the answers at present. This is an emerging landscape. And it's important, therefore, as patients, that we continue to ask questions. But equally, in terms of hematologists and hepatologists, it's important that we keep up the conversation between patients and healthcare professionals about what we do know, about what we don't know, and about the new advancements when new information does come to light. As we know, hepatologists are rarely part of the multidisciplinary team in comprehensive care centres. And so Vincenzo asked at the start, is there space for hepatologists within the comprehensive care team? The answer to that is undoubtedly yes. We also know, and Vincenzo touched upon this, that liver health and general health are closely linked. I heard someone say recently, and I've repeated this at several talks recently because it's something that's really resonated and stuck with me, that we need to stop just treating the hole in the patient and we need to treat the whole of the patient. So as well as treating our factor deficiencies, be it von Willebrand's, factor 8, factor 9, whatever it may be, we need to also think more holistically about the patient. And Vincenzo really helpfully mentions things like diet, alcohol and physical activity. How many people know what safe level it is for them to be drinking? How many people are eating healthily, for example? And how many people are being physically active? And as I said, I've deliberately used the phrase physical activity rather than physical exercise. I think the phrase, although I'm a big proponent of physical exercise, I think that can sometimes be intimidating to people, particularly with bleeding disorders. So what that might mean is something simple, such as making sure you're eating well, making sure you're not drinking too much, perhaps making sure you're not smoking, and making sure you're maybe getting 10,000 steps in a day. It doesn't necessarily mean you need to put a pair of trainers on and go out for a run or ride a bike or go to the gym or do all those various things. There are lots of ways in which we can look after our physical health and be physically active without necessarily having to undertake some sort of serious degree of exercise. Of course, exercise will always be beneficial and helpful, and we'd encourage it. But I think we can think about the things we can do rather than things we can't do at times. A significant challenge, as we know, is that bleeding disorders are often characterized by lower limb damage, which means that putting on weight becomes an issue. And then once you put on weight, that puts pressure on the lower limbs, and then you put on more weight and you put more pressure on the lower limbs, and it becomes a vicious circle. And it's a difficult chain to break in the cycle. We also know, as well as physical health, that people with bleeding disorders experience significant amounts of pain. And of course, that can be linked to lifestyle issues. If you're in pain, you may turn to food or to alcohol or something else as a crutch. And again, that becomes part of that vicious cycle in terms of impacting on physical health and then impacting on your mental health, and round it goes. There is, of course, as well, a lack of understanding sometimes about healthy lifestyles, about things such as non-fatty liver disease and obesity. So those are some of the challenges we face as a community. There are therefore new challenges which potentially may restrict people's access to new treatments. As I say, today we're focusing very much on liver health, but tomorrow it could be kidney health. The next week it could be cardiovascular health. And so I want to talk to you about a concept that I'm referring to as, is it on the slide? I've not put it on there, as prehabilitation. Some of you may have had surgery. And of course, some people who don't go through elective surgery as a result of an accident, you'll have to go through a rehabilitation process. Some of you who go through elective surgery may have discussed with physiotherapists the concept of prehabilitation, the fact that if you know you're going to have an ankle fusion, for example, and you're going to be off your feet for several weeks, several months even, that you might start to do some exercise and build up some muscle bulk in advance, so that when you are then off your feet for a significant period of time, the gap between you being able to get back to your normal life, or even better than where you were before, is reduced. And I think, as well as physical health, we need to look at that in terms of treatment. We need to be, as patients, preparing ourselves for future treatments that may become available. So as I said, what's the solution then? Liver health needs to be put back on the agenda for all, which is why it's great to see this conversation continuing from last year. Hepatologists, once again, need to become involved in the care of patients with bleeding disorders and need to be integrated again as part of the comprehensive care team. We have to acknowledge as well that at patients and as comprehensive care centres, that sometimes we don't have all the answers at this stage. We have to be upfront with each other about what we do know and what we don't. Brian's going to talk about this in a few moments, but patient organisations need to raise the profile of liver health with patients and healthcare professionals and provide information and guidance to people with bleeding disorders. And we need to ensure that patients have the information they need to make informed choices, because there are, of course, so many choices out there to make these days. So we need to ensure that we're aging well. And as I've said, we need to treat the whole of the patient, not just the hole in the patient. Patients may need to be less passive and more active in terms of their care and take charge of their conditions. We've seen from the European Haemophilia Consortium and from the Haemophilia Society in the UK, encouraging physical activity, which has always been important. But I think after COVID as well, some people became more sedentary. It's important we encourage them to get back to their pre-COVID levels or even improve from there, which is why it's great to see campaigns such as the This Way campaign at EHC conferences with organised walks, and the Haemophilia Society currently organising its race around the world. I think we arrived in Paris a day or so ago on our trip around the world, so we're nearly back in the United Kingdom. Back in 1961, President Kennedy visited NASA, and he talked about the fact that the Americans and NASA wanted to put the first man on the moon in the next 10 years. Sometime later, he went back to NASA, and while he was undertaking a visit, he spoke to one of the janitors there who was mopping the floor. And he said to the janitor, he said, "What are you doing?" And he said, "I'm helping to put a man on the moon." He didn't say, I'm cleaning the floor because someone's dropped a milkshake or a cup of coffee on it. He was cleaning the floor at NASA, and he said his role was to help put a man on the moon. And I think that's really important for us to consider, because you don't need to be a distinguished hepatologist like Vincenzo to be part of the solution in terms of bleeding disorders and liver health. I've talked already about the concept of prehabilitation in terms of elective surgery, but we know that physical health is linked to mental health. Mental health is linked to pain, and pain is linked to physical health. So we need to think about this as a circle and how we can help complete that circle or break the cycle in certain circumstances. And so, as well as hepatologists, physiotherapists are equally important in this conversation. Physiotherapists aren't just looking at your physical health, they'll also be helping you with things like liver health too, and psychological support. There's been quite a lot I've read in the last week about complementary therapies. And in fact, there's an article in the Times today discussing talking therapy, which can help to reduce future heart problems. It talks about people who suffer from depression, if they suffering a 72% increase in heart risk. So you can see there how someone's mental health directly impacts their physical health as well. And so as we enter this exciting new area for treatment, it's incumbent on us all to continue this conversation and ensure that when new treatments such as gene therapy and others that we perhaps don't know about coming down the pipeline, that when they do come to market, that everyone is able to take those opportunities should they so wish, and ensure that no one is left behind. Thank you very much.
Thank you, Clive, for giving us a really good overview of what the patient sees and what the individual sees around how they can actually interact on a day-to-day basis with getting solutions to possibly try to avoid Vincenzo's, as good as his personality is, trying to avoid going to the hepatologist is probably the key thing that we want to do. Brian, going over to you now on the NMO side, the patient organizations, what are the points that you feel that we can pick up off in the previous two conversations that the patient organizations need to be addressing and dealing with in terms of liver health?
Thank you, Declan. So liver health and the role of NMOs. So just to reiterate some of the points that Vincenzo made earlier, the long-standing engagement with hepatologists has been due primarily to link the prevalence of hepatitis C in hemophilia in the past. Now, several years after the direct-acting antivirals are available, we hope that the majority of people with hemophilia have been treated and achieved a sustained virological response. Having said that, we did a survey back in 2017, which showed that many countries did not know how many people with hemophilia they had with hepatitis C, or indeed how many still required treatment. So we can't assume this is the case. There's now a renewed focus on liver health, primarily because of gene therapy and the transaminitis that is very common with the phase 1, 2, and phase 3 clinical trials in terms of gene therapy. But I think it goes beyond that. Following hepatitis C clearance, many people with hemophilia who did not have cirrhosis or severe fibrosis were discharged from follow-up with hepatology. And if they had cirrhosis, there was continued renewed monitoring, routine monitoring with FibroScan, ultrasound, liver function tests, blood tests. But the concern I have is that the risk of progression to cirrhosis or HCC is not normalized post-hepatitis C clearance. It's lowered, but it's not normalized. And there have been reports of significant numbers of people with hemophilia whose liver disease progressed despite no cirrhosis or severe fibrosis. And Vincenzo's slides earlier showed that 16% of the cohort in Milan had advanced liver disease in the post-hepatitis C era. And I think ruling out cirrhosis post-SVR is also difficult. So I think we need to reevaluate new criteria for which people with hemophilia should be monitored, how often, and using which diagnostic tools or algorithms. And I think some possible actions that could be taken, I think a joint EHAD-EHC statement on this would be very welcome. Collaborate with work that I know is ongoing with ISTH. I'm not sure if WFH are doing anything on this. Perhaps collaborate with EASL. A new EDQM recommendation on the need for routine liver monitoring of people with hemophilia for liver disease. Because in my view, countries or centres will not act unless recommendations or guidelines are in place from respected international sources. So even if haemophilia societies are talking, there are comprehensive care centres about the need for liver monitoring, liver disease monitoring in people without cirrhosis. I don't think they will act in any concerted manner unless there are recommendations or guidelines issued, for example, from EHC and EHAD jointly. So the role of NMOs, well, alcohol awareness, not just in gene therapy recipients. And maybe when somebody says, well, I just have the one drink, define what you mean by one drink. The role of BMI and fatty liver, which can impact all people with haemophilia, including those who do not have a history of hepatitis C, promoting exercise and movement, healthier food options at conferences and events, because the risk of liver disease is not just post-hepatitis C, it's also linked to obesity, fatty liver, high BMI, diabetes. And also promote any regular liver health monitoring guidelines if there are new recommendations issued, and try to make sure insofar as is possible that there is adherence to those new recommendations. Certainly in Ireland, we had a multi-year research project called IPATH, the Irish Personalised Approach to Treatment of Haemophilia. As part of that, there was a substantial proportion looked at physical health and physical activity and BMI and so on. And this was led by Megan Kendi, a physiotherapist. And her study, where she looked at a lot of people with severe and moderate haemophilia, showed that 64% of people with haemophilia were either overweight or obese. And that also many of them were not hitting the recommended minimum exercise minutes per week. And there have been several publications in haemophilia relating to that research. It was very comprehensive. Each individual got a full breakdown of their body fat composition and a full breakdown of their physical activity levels and recommendations. And on foot of that research, we were concerned when we saw those outcomes, those results. So on foot of that, we took a number of initiatives. We started a weekly physiotherapy and exercise program. Initially, these were carried out for 4 different groups: men with haemophilia over the age of 50, men over the age of 35, women with bleeding disorders, and von Willebrand's. There is now one class which has been continuing for over 2.5 years. It's a weekly online class with a haemophilia physiotherapist, 45-minute class, including warm-up, aerobic exercise with some high intensity moves, strength circuits, warm down and flexibility. And this is really, really good. The only equipment required are a yoga mat, a bottle of water, and TheraBands, which have been provided by the Irish Haemophilia Society. When you look at the outcomes of this to date, we surveyed the individuals last year, and the vast majority said that 75% said they benefited a great deal or a lot from the exercise programs. In fact, on foot of these programs and advertising that on Twitter, similar classes are now running in the haemophilia centres in Japan and in Nigeria. And we're actually adding Pilates classes from next week for both men and women. So we'll have Pilates classes on a Wednesday night and physio exercise on a Tuesday night. And I think some simple measures could also be taken. So healthier food at conferences. We have replaced biscuits at our coffee breaks with fruit. Now, I did have one individual who suggested this to me about 2 years ago, that we should have fruit at the coffee breaks. And then last year, after we took this initiative, the same individual came up to me and said, "Where are the biscuits? I want a biscuit." I said, "No, we've replaced it with fruit." He said, "No, I meant I wanted biscuits and fruit. So you can't have both." So we've actually replaced biscuits with fruit at the conferences. We're trying to give the children healthier meals, exercise sessions during the conferences for the children and the teenagers, really to integrate a culture of physical activity and exercise, even for the young children. So we actually have exercise sessions now at the conferences led by qualified personal trainers. And also one of the pictures here on the left is from the Croatia Haemophilia camp, where they do Nordic walking, a really nice activity. I'm hoping we might see some of that at the conference in Croatia in October, and also promoting alcohol awareness. And that's my talk. Thank you.
Thank you very much, Brian. So again, if you have any questions, please pop them into the chat, and we can address them. But we'll take a couple of minutes to go over some of the comments, and I feel like I should go back to Vincenzo after listening to the other 2 speakers. You know, one of your slides highlighted a high proportion of arthritis and pain in patients with a bleeding disorder. the knock-on effect then in terms of obesity and overweight, and then the knock-on effect again of that in terms of liver health. How do you manage that conversation when people have been referred to you from the bleeding disorder world?
Declan, do you want me to answer?
Please.
Yeah. Honestly, you pointed out a very important aspects related with the hemophilia word. It's true. People with hemophilia, due to problems to their joints, do move less than people without hemophilia. And this has been clearly demonstrated also in observational studies, demonstrating an association between the problem to ankle, for example, and the obesity. This can have a great impact on the liver because steatosis that can evolve toward steatohepatitis can be worsened by this problem. So I appreciated very much the suggestion from Brian of using several activities to involve people with hemophilia, even when from the beginning, from their childhood, just to educate them for the importance of the movement. And the Nordic approach is widely used in medicine, and possibly it can give an advantage also for the liver. Unfortunately, now I don't have specific data to show you that a specific exercise can have an impact on the liver disease. In Barcelona, they tried to measure the impact of the weight reduction on portal pressure, and they had a very important data with positive results. If you have weight loss, you reduce portal pressure. This is an important point that we have to use to persuade people to perform exercise, also with the aim, the focus on liver health, I think.
Thank you. And in terms of patients referring to you, often what we see is they get referred from the hematology clinic to you, and there can be quite a difference in terms of how we respond hematologically, which is if there's a bleeding event, it's response quite quickly, whereas the plan with hepatology is slow, long progression. How do you talk to patients when they get transferred or referred to you initially with maybe just a high liver enzyme test?
Yes, I start with clarifying them why they are in a liver unit and they need a hepatologist. I think it's important for them to not scare people about having an additional specialist managing them, but also to make them aware for the importance of this activity that we have started in our center by screening all patients with hemophilia for a potential liver disease. After this premise, if they have an increase of transaminases, of course, I have to look for the cause. And the history, their previous history, can give us several hints to understand if they are or not already known for a viral etiology, if they have received or not a successful etiological therapy to control HBV replication or ACV infection. And finally, I start with the routine screening with also an echography, ultrasound, and a general biochemistry. We start from them and specifically start to a second level of examination depending from the first results.
Okay, thank you. Brian or Clive, I'll go to Clive first. I really like this concept of a culture of physical activity that Brian mentioned towards the end. But one of the difficulties, I think, in having a liver specific or a liver awareness conversation is probably due to the difficult history that we have had related to this. How do we get that message out that it is about overall health, no matter where you've previously come from within the community? How do you deal with that in the NMO?
I think we know that we've got different cohorts of the population who that conversation might need to be different for. So we need to tailor that conversation. Certainly in relation to the younger generation and children, lots of us will probably remember growing up being told what we couldn't do. And we need to turn that conversation around and start to talk to people about what they can do, and then to encourage them to do those things. And as ever in life, one thing isn't going to be right for everybody. So it's important that people explore, experiment, try these things and work out what's right for them, be it Nordic walking, be it running, or be it swimming, whatever it happens to be, whatever that person is particularly enjoying, then that conversation is important there. But then I think we need to change the conversation in terms of the older population, in terms of, I say, it being preventative, and the fact that people need to start considering about how they're going to age well, and the fact that just because they have got poor joints, for example, that doesn't mean that they can't go and do things as well, that shouldn't hold them back, that again there might be other things they can do. You can do aqua jogging, for example, which completely takes the impact out of your ankles and those sorts of things if that is the issue. And again, it's about exploring and experimenting with what might be right for them, not just to keep them where they are, because I think lots of people think about health, particularly with haemophilia and bleeding disorders, as maintaining the status quo and not getting any worse. But actually, I think there's an opportunity for some people to actually lead better lives with the new treatments that are coming along. And because I think lots of people, I think as a human beings, we genuinely don't like change. And so when something new comes along, you might say, no, I'm happy as I am, thank you very much. But it's about opening people's eyes to the possibilities that actually by changing their treatment or changing what they're doing, they may actually be able to improve their lives. Because I think lots of people always think that they just want to stop it getting any worse. But actually, I think in the current climate, there is an opportunity for many people to improve their lives, not just maintain the status quo.
Thank you, Clive. Brian, do you want to add to that one before I ask you another question?
Yeah, I don't think it's that difficult a conversation if you tackle it holistically. So, we have a cohort in our membership who have got past hepatitis C, who've cleared hep C. They're one cohort, but there's a whole cohort who never had hep C. There's the younger people. So we talk to them all about healthy exercise. We do sessions on healthy cooking at some of our conferences. At one of our hepatitis C meetings, for example, we had an alcohol-free drinks reception because people complained that alcohol-free beers and wines tasted awful. Well, we got a whole selection of them so that they could find one that they liked or could tolerate. I really liked the Nordic walking session at the Croatian conference because they also checked people's blood pressure beforehand and after. So there was some study methodology around it. And I think we also do yoga, Pilates, exercise at the conferences. On a Sunday morning at our October conference, everybody wears tracksuits. We do the yoga, Pilates, or exercise for the entire family. So it's not just the person with haemophilia, it's the partner, it's the mother, it's the children. So I think it's really creating a culture where, look, with new therapies, post-hepatitis C, where all the new haemophilia therapies, we should be looking towards good health, good mental health, good physical health, in the same way as other members of the population. So there's no reason why we shouldn't take a more holistic view of this.
On your point, and you brought this up in your talk, that you'd like to see a joint EHAD, EHC statement or guidance on this. So in terms of that guidance or information, we have the hepatologists have the EASL guidelines, we have the hemophilia guidelines. So in terms of that joint statement or joint conceptual idea, is it more for the hematologists to make sure that they're covering the hepatology, or is it for the hepatologists to be aware of the considerations as they go into hematology? Because as we move into the kind of gene therapy space, and we'll get into that in a minute or two, this gets a bit more complicated.
In my mind, it's primarily for the hematologists and for the haemophilia treatment centres to understand the requirement to maintain that link with hepatology, to understand that there may be people with haemophilia who have cleared hepatitis C, who do not have cirrhosis, but who will require ongoing monitoring where there are other risk factors as well. And as I said, it's not everybody. I think Vincenzo's made it clear that there will be some people who need to be monitored on an ongoing basis who do not have cirrhosis, others will not. But it's really making sure that conversation takes place in a structured way, because frankly, at the moment in many countries, it's not. I am concerned that hepatology centres are overrun with people with hepatitis C and other liver diseases, and when they clear somebody, they get the SVR, that's it, off you go, we don't need to see you again. And I think the haemophilia centres, in my view, have an obligation to maintain that link and to make sure that people who have other risk factors, who have cleared hepatitis C, are monitored on an ongoing basis if required. But who those people are, exactly which subparts of the population, that's where the guidelines or recommendations should come in. And I think without the recommendations, you won't see the action.
I fully agree. Vincenzo, do you want to comment on that?
Me too. I fully agree with Brian's comment, and I would like to stress that the main doctor for patients with hemophilia is the hematologist. Is their referral doctor. So I think we have to push our efforts to start this collaboration, starting from the hematological centers. The hematologists have to start sharing the clinical issues of their patients with the hepatologist also. Going a bit out of the optimistic view we had after the great achievement of DAA against hepatitis C, or the nucleotide analogs that significantly improved the quality and the quantity of life in patients with the HBV. We know that it's okay. This was a great achievement to change the natural history of patients with chronic hepatitis, but there is a subgroup that continue needing going to the hepatologist. And I think if the hematologist recommend this to patients, it would be better.
Thank you, Vincenzo. I'll ask one last question, because we've only 2 or 3 minutes left, and I'm not seeing any questions come into the chat. So we're moving into a world of not just in the bleeding disorder space, but generally in terms of medicine, into gene therapy. And we're seeing new challenges on the liver in relation to gene therapy. So I'll first go to Vincenzo, and then Clive or Brian, if you want to jump in afterwards. How does that challenge you as a hepatologist coming into a condition that is, or coming into a space that is still very unknown as to what's going on in the liver when gene therapy is being delivered?
Yes, my main challenge as a pathologist is interpreting the data published up to now about the randomized controlled trials. For a hepatologist, we need the hepatological point of view. We would need more data. Even the single case of hepatocellular carcinoma that we had after gene therapy, after 1 year of infusion, would need more data to understand if the risk is real or not. So again, the close collaboration among hepatologists and hematologists is a key point to improve the health in this setting.
Thank you, Brian. Or
well, I think with hemophilia gene therapy, the science has outstripped the biology in terms of the pace of improvement and availability. So we actually don't understand how the AAV-based gene therapies work in the liver. We don't understand the variability in response and durability and so on. So I think there's more work to be done in actually understanding the basics of how gene therapy works in the liver cells and how it impacts the liver. And I think there's a lot more work to be done on that. And I'm sure we'll see that as we go forward towards generation 2 of the hemophilia gene therapies.
Thank you very much. So with that, we've reached the top of the hour. I want to say a very big thank you to our 3 speakers. It's been great speaking with you for the last hour, and to give us guidance of of what we really need to do to make sure that we age healthily, especially in relation to our liver. So with that, I would like to say thank you very much, and thank you for joining us, and happy World Liver Day in World Hemophilia Week. Have a good day, guys.